Ladies and gentlemen, welcome back. Let me introduce Professor Selcuk Sılay. His pediatric surgery department. I'm very happy to work with him. I change a little bit the order because Dennis is about to come. Therefore, if you don't mind, and I want to start with Selcuk. Selcuk, would you like to share your presentation with us, if you don't mind? Click on share.
Yes, sure. Yeah, I will do it.
Excellent.
Okay.
Good. Carry on.
So, thank you. Hello. So, thank you very much, Professor Cihat Şen. It's a really great honor for me to join this meeting. I'm also very honored to be working with you in the same hospital as well. So, you're really an inspiration for us. So, I'm going to talk a little bit about the neurogenic bladder, conservative and interventional approaches, and of course with the urological perspective, because I'm a pediatric urologist as well. We are really getting used to those kinds of Zoom meetings, and it changed some of our habits. Like this, the first day after at work, after the new normals, now we are wearing our clothes just like this. So I think many things will change, but this Zoom meeting really enabled us to reach even a lot of countries, as you mentioned. So this is going to be the overview of my presentation. I will talk about the conservative treatment, interventional treatment, and then the take-home messages as well. As you well know that spina bifida is one of the most common birth abnormalities, and 9 out of 10,000 births are diagnosed with spina bifida. And myelomeningocele is a form of spina bifida, and the most common reason of neurogenic bladder in children is myelomeningocele. You know this very well, actually, and this is a classification. So the whole list is the types, the classification of spina bifida, and this is actually what we see: the myelomeningocele, the protrusion of the spinal cord segment and meninx through a bony defect. First of all, what I want to say is that we have a hope, because the total numbers in the world of spina bifida is declining. This is good. And we know that the folic acid supplement plays an important role during pregnancy, and the survival rates of those children are increasing with multidisciplinary approach and treatments. And the major goals, the urological goals in the treatment are: the first one is, of course, preserving the kidneys, improving the bladder functions, and improving the bowel functions. This is also very important for us, because when the child has got constipation, this is affecting the urinary system by causing UTI and other problems. Of course, when the child gets older, there are also sexual problems, continence problems, and fertility, which are affecting the quality of life as well. Some general informations, as you know that 12% of the newborns may not have neurourological symptom. In other words, 90% of the children has got some symptoms. So it's a huge amount of children. And 60% of the newborns with normal upper urinary tract may have worsening in the long run related to urinary tract infection or vesicoureteral reflux. So close monitoring in the first 6 years of life is really critical for us. Again, 50%, in one of the study, it has been shown that the patients with spina bifida who are at the age of 29 years old, half of them are incontinent, and at least 1/4 of them have upper urinary tract deterioration. Okay, so let's have a look at the prenatal management. I think you talked about this, but just I will pass it very superficially. I think this is a very historical study that you all know, because it's a randomized trial which is published in a very nice journal, New England Journal of Medicine, about 10 years ago. And in this study, half of the children were randomized to be performed as a prenatal surgery, prenatal closure of the spinal defect, and half of them underwent postnatal. And the primary endpoint was of the study was fetal and infant mortality, ventriculoperitoneal shunt necessity after birth, and mental motor development in the first years of life. So this was one of the most striking studies in the last decade. At the end of the day, the perinatal mortality were found similar. VP shunt placement, ventriculoperitoneal shunt placement, was less for the prenatal group. This is in favor of prenatal intervention. Another favor was that the mental and motor development was also better in the prenatal treatment. However, related to preterm birth and uterine dehiscence, the study needed to stop because of some ethical problems. However, it has been published in New England Journal of Medicine. And those children were followed. Until when? Until last year. And last year in Journal of Urology, the long-term results of those children have been published. The same children, the same population. And when they become at 7 years old. And what they have seen was that the clean intermittent catheterization requirement was higher in children who were treated in the postnatal period. I mean, in the first 24 hours or 48 hours of life. So it was also in favor of prenatal management. Also, when we look at the volitional voiding, again, prenatal treatment was superior. But the necessity of further operations, just like augmentation, cystoplasty, and other major surgeries, were similar between the groups. So actually, both of the studies were in favor of prenatal surgery. However, they all conclude that still we cannot recommend routinely, or still it's not the routine procedure. So let's come to the neonatal management. As you know, that the first stage is the primary closure of the defect, and the timing is very important, recommended within the first 24 hours by neurosurgeons, of course. And when the defect is closed and the patient is referred to us, to the urologist, we assess the bladder functions. How we do it? We check the post-voiding residual urine, and we check the maximal detrusor pressure. How do we check this? By urodynamic study, of course, and video urodynamic study is preferable because we can see the reflux if present. So the child do not have to go 2 different studies. If you have video urodynamics, it's an advantage. And also we assess the upper urinary tract functions, like we check the creatinine levels, and we look if there is hydronephrosis or not. So when we do the urodynamics, we have 4 different scenarios. And one of them is about external sphincter. You know, external sphincter is below the bladder. And when it contracts, we stop voiding. When it's relaxed, we start voiding. So in these 4 different scenarios, either sphincter or bladder is overactive or underactive. And it can be all of them. Both of them can be underactive, both of them can be overactive. The worst scenario is that the first one, the overactive sphincter and overactive bladder, because the patients have higher intravesical pressures, which may cause kidney damage. So let's have a look at the conservative treatment. Conservative treatment, we have 2 different types. One of them is expectant management. In other words, active surveillance. I mean, we touch the patient when something happens. The other treatment is a proactive treatment, which means we immediately start the treatment. So let's have a look at it. In expectant management, we do not start clean intermittent catheterization immediately right after birth. We wait. We don't give anticholinergics. We start with family education, regular follow-ups, ultrasound, and in case there is a problem, then you start either catheterization or anticholinergics or further procedures. However, in proactive management, which is recommended now, which is the real treatment actually, right after birth, we start 4 times a day clean intermittent catheterization. I think this is very important. I will show you some data about it. And also we start anticholinergics, oxybutynin. You know, it has got oral format, so we can use it easily even after birth. So this is one of the studies checking the long-term follow-up in spinal dystrophism. All patients were followed with active surveillance, with expectant management. And in this case, the patients were followed until 16 years. And the start of the clean intermittent catheterization was after 3 years old. It's late, it's a little bit late. And they have seen that like 1/6 of children has required augmentation cystoplasty. You know augmentation cystoplasty well. We create the ileum and put it on the bladder to enlarge the bladder capacity. And the urinary continence rate was 62% and the upper urinary tract deterioration rate was 12%. When we come to proactive treatment, this is another study published in Journal of Urology. This is one of the respected journals in urology. They start treatment, clean intermittent catheterization right after birth, and this really helps the family to accept this situation in an early period. And they have seen that the renal complications decrease compared to the expectant management and the necessity of augmentation cystoplasty. I mean, this is really a major surgery and this changed the life of the child. And this is really decreased, twofold decreased when compared to the expectant management. So we continue with the conservative treatment. Those are the options: anticholinergics, antibiotic prophylaxis, alpha blockers, antidepressants. We can increase this list. And we have different follow-up protocols in Europe and in United States as well. So this is our European pediatric urology guidelines. I'm also a panel member in the last 5 years. I'm really proud to be there. So what we try to do is we put the evidence-based medicine. Every year we update it. And according to the guidelines, first, when we see those patients, we start with anamnesis, physical exam, laboratory, and then the imaging studies. When we say imaging studies, of course, we're talking about the urinary ultrasound, urodynamics, preferably video urodynamics, voiding cystourethropy. It's also mandatory, and DMSA scan in order to see if there is any renal scarring or thinning of the renal parenchyma. So this is our algorithm for the management of children with myelodysplasia. Here you can see that I will try to summarize you. It's a long one. We start the anticholinergics if that story is overactive. How we find if it is overactive? By urodynamics. If it's overactive, start anticholinergics immediately right after birth. We start prophylaxis if there is an accompanying vesicoureteral reflux. Because if you don't start prophylaxis, the children will have much more febrile urinary tract infections, which will cause kidney damage. It's obvious. Botox treatment, botulinum toxin treatment, for overactive bladders with upper urinary tract deterioration is recommended. What does it mean? You start anticholinergics, you educate the family, you start clean intermittent catheterization. However, this patient still progress in the upper urinary tract, has problems. Then we can go with botulinum toxin injection treatment, which is really changed the play in all over the world. And then if the botulinum toxin injection fails, we can go with augmentation cystoplasty. In patients with underactive bladders, in other words, lazy bladders, some people call it, individualized treatment is decided according to the patient's situation. And as I said before, we should start the clean intermittent catheterization in every child right after birth and continue in patients who has got high post-voiding residual urine. I want to underline this. We don't continue clean intermittent catheterization forever. We start the CIC, but if the residual urine is low, then you can decrease the numbers like 2 times a day, 1 time a day, and then you can stop it. It's up to the patient's situation. And according to the European guidelines, we have some strong recommendations. First of all, as I said, the urodynamics in all children is mandatory. CIC, clean intermittent catheterization, should be started right after birth. You start anticholinergics, botulinum toxin in refractory cases. One more important thing, which is strongly recommended, is the aggressive treatment of constipation. How? With the laxatives, rectal suppositories, irrigation, some surgical procedures, which we call it MACE or Malone procedures. And augmentation cystoplasty is recommended in high-risk patients who doesn't benefit from conservative treatments or botulinum toxin. When we come to American guidelines, actually it's similar to the European guidelines with just a little bit discrepancies. This is one very nice study published 4 years ago from 9 centers of excellence, spina bifida centers. And the main target was designing a follow-up protocol, which means the standardization in the follow-up. I want you to look at this chart. I know it's a big chart to follow. However, it is hanged on my wall in my office, because when the children comes, then I check what is the age of the child and how to proceed. So first of all, when we see diagnose the patient at birth, we start with family education. You see, within the first week, we do the ultrasound. Between 1 and 3 months, we do the DMSA scan. And by 3 months, I mean, when the child becomes 3 months old, this is one of the most asked questions. When are we going to perform urodynamic study in children in spina bifida? It's in 3 months, when the child becomes 3 months old. And then we check with the VCUG, and then the rest of it. So this is another position of the chart. Just to check the red line, renal bladder ultrasound. We do it at birth, 3 months old, 6 months old, every 3 months, and then annually until 5 years old. At the end of the day, by using the conservative treatments, 2/3 of the patients can stay dry. This is very important. We should not underestimate the effectivity of the conservative treatment. So what if fails? What if the conservative treatment fails? Then we should go for further surgical or interventional procedures, of course. But how to assess the failure? There are some things that we need to check. One of them is we do 4 times a day or sometimes 6 times clean intermittent catheterization. If the child has got urine leakage between the catheterization, this is one sign of a failure. The second one is the incontinence regardless of the maximum dose of anticholinergic use. The other one is upper urinary tract deterioration. So I'm coming to the interventional treatment. We have several options, and I told you botulinum toxin, sacral neuromodulation, ZAO procedure, augmentation cystoplasty and Mitrofanov procedure, ACE or MACE procedure or Malone procedures, and bladder neck surgeries. The main goal of botulinum toxin injection is to increase the bladder capacity, decrease the intravesical pressure, and repeat injections are always possible. Sometimes we do botulinum toxin injections 10 times, 20 times. It doesn't change the outcome. I mean, it's still effective. According to the European guidelines, the effectivity is between 65 to 87%, and the maximal detrusor pressure decrease, and also we increase the compliance. And the most common dose used is 200 international units. So as you see that the level of evidence is 2B for the botulinum toxin injection. There are some systematic reviews, but no randomized controlled trials showing the benefits of the botulinum toxin. It's safe and effective. Can botulinum toxin injection decrease the necessity of augmentation cystoplasty? I mean the major surgery? The answer is yes, and this is one study about it. In this study, they found that the botulinum toxin can decrease the need for augmentation. And because in 14 of 17 patients, they didn't go for major surgery. Can it be repeated? Yes, it can be repeated even for 11 times. Is it effective for low compliance bladders? Well, it's sparse. because in fibrotic bladders, we know that it's not really effective. And the predictor of success for botulinum toxin is actually the bladder compliance. If it is low, then the success decrease. I'm coming to the end of my presentation. It's a sacral neuromodulation, you know well, it's implantable. It can stimulate the sacral nerve roots. But however, the effectivity is not proven for neurogenic bladder. We know that it is effective in non-neurogenic bladders, but in neurogenic bladders, we don't have enough data. You know Zhao procedure, especially the neurosurgeons. They do laminectomy between L4 and S2. It has been shown to be effective, but it's still low evidence because there is conflicting data. For instance, in one study, it has been shown that majority of the patients were satisfied. However, in another study, it's useless. So still, there is much more data is required. Bladder neck lengthening is another procedure that we use to increase the bladder neck resistance. You see the bladder neck here and the bladder. So what we do is actually lengthening the bladder like Heineken Mikulik style. And then also we can wrap a sling procedure there. Bladder augmentation is performed for bladders with low capacity and high pressure. We can use ileum or ureter if possible. Sometimes gastrocystoplasty is performed, but it's not recommended anymore. The complications of augmentation are infections, bladder stone, mucus formation. We really have trouble about it. However, if you use ureter, ureterocystoplasty, then there is no mucus formation. Electrolyte imbalance, sometimes we lose our patients because of severe acidosis and adenocancer development of the bladder in the long run too. So my final slide as a take-home message, proactive treatment in spina bifida right after birth is recommended. Bowel management is crucial. Botulinum toxin is effective if the conservative treatment fails, and augmentation cystoplasty is the last option if the upper urinary tract gets worse, even after the regular treatments or conservative treatments. Thank you very much for your attention, and thank you, Professor Shen, for the opportunity.
That was a very nice and useful overview on the topic which we needed. Thank you very much, Selcuk. You've done it very nicely.